Testing 2 2. Testing. Testing 2 2. Testing. Testing 2 3. Testing. Testing 2 4. Testing. Testing 3 8. Testing. Testing 3 8. Testing. Okay. 2 8 1 8. Testing 2 8. Testing. Testing 2 8. Testing. Testing 1 8. Presenter mic. Testing 1 8. Presenter mic.
Go back to the other one, please.
Huh?
Go back to the other one, please.
Testing 2 8. Testing.
One more time.
Testing 2 8. Testing.
It's kind of low.
I got one bar from the top on in the back on 3-8. All right, yes, Mom.
On 2 8. Testing 2 8. Testing.
On 3-8, right?
2 8.
Yeah.
Testing 2 8. Testing.
I got you all the way up to 3-8 now.
Okay. Testing 2 8. Testing.
Okay.
I got it all the way up to the top on red in the room, Jeff.
Okay.
I got the mic down like one left.
So it's good online. It's not so hot out here.
Up there, okay.
Online is perfect.
I want to see what this sound out. Where we can say whether it's the mic or the speaker. Test.
That was good.
That's good back there, huh? Yeah, so we know it's the mic instead of yeah, instead of the speakers. We know it's the mic. Because I got this.
Okay, let's.
Test.
That sounds okay.
Test.
We may have to switch this out to a goose.
To a gooseneck.
Because you can't.
2-8 or both of them.
Just let's try just one. And William, move this board mic a little closer to the annotator.
The second one.
Yep. And let's change that out to a gooseneck. We want to take it down though.
How are you doing this morning?
Okay, and you?
A-okay?
Good.
Yeah?
Where all this?
Testing 2 5. Testing.
Okay. Try it one more.
Testing. Did you turn 2 8 on for me?
Yeah.
Testing 2 8. Testing.
That's better. Hello.
Hello.
Hello. Hello. It echoes a little in here, but hello, hello. So yeah, maybe we take 28 and 18 down a little bit, but we leave them out here just in case.
Yeah, I've got them all in the yellow, nothing's in the red on.
Okay. In what?
Nothing's in the red, they're all down in the yellow.
Perfect. And it's, I can hear it out here real well. William, talk into it, please.
Hello.
Dr. Schrader. If I can have everybody's attention, we will call this meeting to order. Thank you very much for being here. This is the joint meeting, but obviously the Finance Committee meeting for Thursday, May the 24th. At this particular time, I've been advised no one is signed in to address this board, so I would move to item number 3 on the agenda, which is the minutes. The minutes are attached to the April 26th meeting. They're on the portal. They've been attached for your review. If there's any comments, I'll certainly entertain those. Likewise, there being none, I would entertain a motion for approval. I have a motion by Mrs. Debose, second by Dr. Weber. All those in favor say aye. Thank you very much. And item number 4, I think before we go to CFO, you're wondering why I'm sitting here. Obviously, Mr. Steve Montgomery chairs this committee, and he called and he is out of town. And so again, that's why you have me, so I'll see if I can get us through this meeting today, and Mr. Montgomery's absent. Robert, your turn.
I'm good. I think the only thing we have is sharing up. I have no matters to update you on. We got full committee meetings today with this and HR right after this. So, Sharon, it's all you.
All righty.
I never feel pressured. Thank you. Good morning.
Good morning.
The one thing I did want to point out before we got into the financials for April is that the First Southwest Hilltop Investment Report was put out on your board portal for the quarter ended March 31st. We received it a few days after the Finance Committee was complete. So if you have any questions on that, I'll be happy to answer them. All right. So for the month of April, our admissions were right on target. It shows yellow, but we were only 17 admissions under our projection, or about half a percentage point. You can see that our case mix index was slightly down as well. However, our length of stay was up again this month, and again, that number is calculated on patients that are discharged. So we had several patients that had a very long length of stay that got discharged this month. And so you can also see that up in our patient days being over budget. For the outpatient look back, our emergency department visits were about 4% under where we had projected them to be. And urgent care was also slightly down. But if you look at the year-to-date impact, we have about 314 patients a day for the first 7 months of this fiscal year come through our emergency department. In addition to that, about 150 a day are coming through the urgent care. So that's a large daily number. And our primary care and specialty clinic visits, we usually look at these graphs, but I just wanted to share with you the actual volume. Each month, this month in primary care, we had 28,865 primary care visits come through. In our specialty clinic visits, the number is slightly lower at 21,500. So lots of patients each month coming through our outpatient areas. For observation cases, we are above last month, but slightly under our budget. And then invasive lab on the top right, you can see we had a very busy month at about 7.5% above our budgeted target. Also, our inpatient and outpatient surgeries remain behind budget, pretty consistent throughout the year, and we talked quite a bit last month about what was causing some of these inpatient and outpatient underages. A lot of changes in protocol in several of our specialty areas. So our psychiatric, you have the inpatient that was about 5% ahead of budget. for the month, and then all 3 of our outpatient areas are trending under budget. Our clinic visits, although you can see by the blue bar, we had, let me point that out to you. This is April. And so you can see that for April, we had one of our highest months that we've had so far to date. And then in our Psyche D, although we're slightly under budget, you can also see by this blue bar that we are kind of trending up from the prior months.
May I ask a question on psych services?
Yes.
Did we just do higher projection for the clinic visits? Because
So looking back, you know, I can't explain exactly why we thought that our clinic visits would be that high, but you can see this red budget is way above our trend line.
Right.
So, you know, I'm not sure. I know that we were going to slightly expand our clinic hours in one scenario, and there were a couple of open positions last year that have gotten filled. But you can see we've had a really large increase from prior year. The beige bar, the middle bar is FY17, and then the blue bar is the current year.
Okay.
And we even show you a 3-year trend, so that's what those little trends are. So we are significantly above last year, just not quite at our budgeted level.
Okay.
Are there any other questions?
So we expected it to be more than it was, even though we're substantially more than it was last year. Now, how does this impact our budget? It seems as though, okay, so we have less expenditures, or, you know, in expenditures because we don't have to service as many. And so, where is that? I want to say extra. Where is that projected loss? How's that helping us budget-wise?
So I can't speak to the psych clinic specifically because I haven't drilled into it that far, but can I give you a philosophical answer on
Absolutely.
that?
I like
Okay.
philosophical answers. To start with those, anyway.
The engineer, the lawyer side of you. So we have, you know, not all services we actually make money on. Some we lose.
I assume we
and some
lose on almost all.
Yes.
Isn't that right? I mean,
And then we watch our staffing very closely for clinic volumes, and if the volumes are not there, then the staff are not brought in to serve those clients that don't show up. So we did not automatically in the psych clinic when we upped the budget, and I think it went up by about 15 or 20% from the prior year level. We did not automatically go out and staff for that number of patients to come through. So on an actual basis, if I were to go back and try to pull what is actually happening in psych, my guess, and it's my educated guess, is that we have staffed for around 300 visits a month, which is where the blue bar is actually coming in.
Right.
We did not staff up to the actual, you know, this red area up here. Now, if those patients show up in the future and it's sustained for a period of time, for 2 to 3 months, then we'll post new positions and bring those staff on.
okay. So when you put together a budget, though, for last year, obviously there's a lot of components to that budget, and so this may be still in the noise, but it's all in the noise, right? Each individual component is small. But there should be, I would expect there's some savings that's occurring here that means we can spend money on something else, or there's the potential of it.
The financials, Warren, are all consolidated. We don't have individual P&Ls for service lines yet. And that's what we're developing with the cost accounting system. We'll be able to do that. So although we may know how much revenue is tracked to psych or surgery or some other
So when we approve a budget, and I expect when we approve a budget, we're approving a very high-level budget, but I guess the question is, so we don't have a breakdown of how we arrived at that budget?
Yeah,
except for historical.
we do.
Yeah, you do.
Yeah, we do, and each.
We overestimated the volume, obviously. That was a miss, but
Okay.
as Sharon said, we're not gonna staff based on budget.
Right, and that's what my question.
Yeah.
So we've got some revenue that's not coming in the door, and we may have a staff position that we haven't filled yet because of that gap. And I guess my short answer should have been, because I don't have profitability on each department, we have budgeted expenses, but we don't have our net revenue by department at that level currently. That would just take a little analysis for me to do offline.
Yeah, my going assumption is that we lose money on everything we do, and so whenever we don't do something, we're actually saving loss that we can apply to someplace else.
So what cost accounting will do for us, and we'll have to discuss it in closed session when we get to that reporting at the beginning of next calendar year, but what that will help us do is show you there are services that we make quite a bit of money on, and there are services that we lose quite a bit of money on, and when you mesh them all together, we are right there at that break-even point.
We hope it's in the black,
So,
right?
yes, we do.
Okay, thank you.
But Sharon,
Yes,
on the VP or the director for site, their budget would show how many FTEs they had budgeted in there and how many of that was actually working. They would be able to look and say, we're over our budget,
yes,
we're under our budget.
yes, we
Yeah, on
can,
that
we can
level.
easily tell you from an expense standpoint, but I think Warren was asking, are we making money? What's the net impact of all of that? And right now, I don't.
Where's the not loss
Right,
Right.
accounted for?
right,
Yeah.
Expenses versus the anticipated revenue,
correct.
and if you had a true cost accounting.
And I can quickly, estimate that. I just have to, it's kind of a manual look until we're able to put that system online, get it all balanced.
And the comment that part of the, I think the good one is that we are staffing to need, not
Yes.
the budget.
Correct.
If that be the case, and we anticipated more, we all not taking people working if we're doing that.
Right.
Which,
Thank you.
Thanks for the question. So on our financial metrics, our days cash on hand is right at 240. It's a natural trend that you're gonna see each year. We receive our tax revenue in January, February, and that's really gonna be the high point for the year. If you look back, just for fun, back here, kind of in the November, December timeframe, we're closer to 160 days cash on hand, which is hovering fairly close to that 150 that we've kind of targeted to maintain. The newer graph on here, that is the newer graph with the available for operations. That does not include the JPS Future Fund, where we have $116, $17 million that have been set aside for future expansion. The way that S&P calculates our days cash on hand would include those board restricted funds. So if you add those back in, it does increase our days to about 287 days versus the 240.
The restricted funds, those are restricted based on our internal decision making.
I used the wrong term, but from an accounting standpoint, it's board designated, correct? So we've taken unrestricted funds that we've received, excess operating cash, and we've kind of set it aside for construction.
Okay, I just,
within our
because
campus.
restricted funds to me means there's a government, there's some source that says we can't use it for something.
Correct, there's donor restricted versus,
Yeah. internal,
You
it's an
took the
internal
engineer,
decision.
you took the engineer hat off, put the legal hat on, you're right.
He's got his accounting hat on today.
Well, but I'm saying is, he's moved, but the
Yeah.
question is, yeah, those were set aside based upon decisions by the board, which obviously other
And
decisions
they are
can be made
board
in the future.
designated, you're
Yes.
correct.
But we can get to them if we had to. I'm sorry, DT, go ahead.
In terms of bond rating, which number are we going off of?
The bond ratings, S&P and Moody's will go off of the total. So this top right is the actual industry standard calculation. Because if we were to butt up against our bond covenant at some point in time, the board could undesignate those funds and bring them in to use for operations, is their philosophy.
And Sharon, for clarification, we still maintain our AA.
We are,
Yes,
yes.
right.
And we meet with...
Very happy to say we
Yes.
hold our AA rating.
I work with S&P and
Right.
Moody's, who are the two rating agencies that the district uses. Each year, I have a phone call with them. And, you know, sometimes mid-year, they have a request for information, so they're constantly monitoring our status. Net AR days tells us from the time that the bill drops, how long on average does it take us to collect an account. This might be self-pay, this could be commercial, Medicare, Medicaid. Right now we're at about 49 days. So we continue to try to improve that, but from an industry standard, that's a healthy number. And FTEs per adjusted patient day remains favorable at 5.64 for the first 7 months, compared to a overall budget target of 5.8. Our payer mix slide, I don't spend a lot of time on this because it's fairly stagnant. This is a year-to-date look, but our unfunded patients, again, are comprised by the self-pay, the green pie of 17%, and the connection at about 22% of charges. And our connection graph, we did have about a 2% increase in connection enrollment this month. So I'm happy to report that for April, the hospital was actually profitable by about $33,000 compared to a $106,000 budget. Most of the variance that you're going to see on April, again, is due to the new URIP dollars that are coming in through our managed care organizations, the Medicaid managed care organizations. And we got about $2.1 million of additional net patient service revenue through that program in April. If you remember, it began March 1, those higher rates, and we got about $2.4 million last month. So that will start to continue to build up year to date, and you'll see it for the rest of this year. Kind of the offsetting piece to some of those dollars coming in is some complex numbers that are down in the purchase service area for the IGT for that new program, as well as the impact of us not offloading those physician contracts through TCICC. We kind of switched from one methodology to another back at the beginning of the year. The other items that have a larger variance is in the salaries. If you remember, we did have quite an overage in our patient day area, so a lot of that is staffing those inpatient beds. Down in benefits, you can see we are slightly over again in our employee health. Not to the extent that we have been, but that's what's driving a lot of the overage that you see there. Then we have some savings down in the supplies and other operating expenses. Part of those are going to be timing, part of those are permanent from what we can see. So year-to-date, we are at $971,000 compared to a $2.8 million budget for operating margin. Is there any questions on the income statement for April?
I have a question, and my question is on your salary expense, and I know you've probably explained it to me before, but how does the salary, looking at we're over in salaries, but when I look back to your graph on the FTEs per adjusted patient day, those don't tie together at all, or?
They do, and let me kind of try to walk you through. So when you're looking at the FTE slide back here, first of all, this is a year-to-date look, but it is favorable. So this just tells us the hours that were worked. It doesn't, or paid. It does not tell us if it was overtime, if there were extra shifts worked, because it's adjusted for our actual volume and the actual hours that were paid. So when you try to translate that over to this line item, what happens is we don't adjust the budget for extra volume. So if you're over budget in your patient days on a nursing unit, you're going to have to bring in extra shifts to work. But our FTEs per APD on just the month is 5.6 compared to 5.8. So we're still favorable on a paid hour. But when you start to put dollars to those hours, it is increasing. And the $31.1 million of budget is set on budgeted volume. So we're over budget in volume on the inpatient areas, which creates additional staffing. So part of that 1.5 million variance is due to volume, and then we may have some premium pay with overtime. So as I explain it to our leadership, you cannot watch just that FTE per APD number. You really have to take it that second step and see what those hours are costing us. What I hope to do next year is actually begin to flex the budget each month. This is the budget that you guys approved for this month back in July and August. So when, if we're able to flex our budget quickly on our new software, we would be able to bring you a budget of, had we budgeted on actual volumes, what would your salary be? And that would kind of take away that whole volume variance.
Good.
So
then I won't ask you that question when you get that. It'll make,
but you
it'll
feel
tie
free.
Into, it's
so,
just that it stands out, and
so because this is our first, this will be our first budget year on the new software. We may have a few bugs to work out, and I may not be able to start producing those in October.
Okay.
But at least we can take a look at those once a quarter.
That would be more meaningful to me to see your cost of labor hours than based on this. Okay. All right.
Software in the budget, I think it's gonna be a huge thing, and eventually, when Warren's talking about getting the cost accounting system in where you can have it by line of business, by department, I think that's gonna be. We gotta get the budget piece done first.
Well, so we are moving to a new software for this year's budget. And then once this year's budget is moved over, we can start to report actuals out of that software. And it's just a transition year. So you may have heard the term Kaufman Hall. We are now moving into the Strata software, which is where our cost accounting build is also held.
It's kind of a two-stage tranche as you move into the budget. It's in the budgeting process this year.
Yes, sir.
We'll be looking at once certified tax rolls and all that's coming. But yeah, Chuck, it's the next step is to go to a more of a cost. We hear that from the county. Let's face it, we hear that from the commissioners about their cost accounting systems. We're headed that direction.
So I remember that was our former CEO claimed. One of the things that he was very much seeking, to be able to look at service line,
Yes, so cost accounting is separate from what we're able to do reporting-wise from the budget. So we're on track for cost accounting to be able to actually start to talk about reporting at the first of the calendar year next year. Now, a lot of those, again, like I told Warren, will probably be in closed session because we'll be talking about profitability and kind of some different strategies that are key to the hospital. But hopefully I'll be able to start to share those with you in February and March. Mm-hmm.
And Sharon, if I could, in reference to that, Chuck, we're definitely headed in that direction. I'm also happy to say I believe BKD, which obviously is recognized as one of the largest healthcare related from an accounting standpoint. I think we're in our third or fourth year. They know we're headed in that direction too, because they haven't had any issues with this budget, but it'll make it a lot easier once we get to that on our systems, both in budget and in cost accounting. I mean, they will be certainly like that also. They spend a lot of time doing a lot of documentation, but they haven't had any major adjustments to the budget in the past.
Right, now just so you understand, BKD audits our actual numbers, and the budget is more of a management guide throughout the year.
Which points were ever made, what Warren brought up, what Bill mentioned. Some of these numbers we said here last year, almost a year back, and had to come up with those anticipated volumes back then. It'll be a lot easier to go in and make some amendments as we go through the budget. So yeah, yes. We're looking forward to getting on that system.
Okay, any other questions on the medical center? Okay, so on a claim, our building counters are continuing to trend about 5% below budget. We do have some open positions in that area that we are actively recruiting for. The bottom left graph is the encounters by department, and based on some of the comments from last month, I have made some slight changes to that graphical presentation. You can't probably read it on the board, but we did break out surgical services. Someone asked for that, and you can see how actual, the yellow compares to the blue budget, and we pushed some of the really small areas back over into the subspecialty. So if you have any questions on that, you can ask or see me after the meeting. Our net patient operating expense, our net operating expense per encounter is a little high this month, but year to date, we're still about 3% under on average. So that's a positive thing. For the month of April, a claim lost $1.4 million compared to $1 million operating loss budget. A lot of the drivers for that was an underage in net patient service revenue. Encounters were down, but we also had a slightly unfavorable payer mix that hit this month. We also have, you can see that our salaries were under, but we were paying quite a bit of contract labor to backfill some of those positions. So the net salary and related expense is right at budget. We do have savings down in purchase service. That attributes to, we thought we were going to be having some contractual relationships with some of the physicians who are now employed. So that's a $200,000 savings in purchase service, and those expenses have moved up into salary. We continue to have some savings and other operating expenses. Most of this is recruitment and continuing medical education for our physicians. The CME will be made up. They're allocated a certain dollar amount to be utilized, and we try to trend that, but we never quite, every year is a little bit different. So So I think those are timing issues. Year to date, Acclaim is still on track with their budget at we've hit it right on there. They're only about $49,000 off of their operating margin target for the first 7 months. Does anybody have any questions on Acclaim?
I want to ask you the question on the CME. Isn't that the program where we went to UNT Health Science Center and they was going to do and we have a contract with them to do some of the CME?
So we use the same terminology,
okay,
but that issue is sitting over on the medical center, and how we provide CME to physicians as an organization at JPS. In the resident program.
That's the one that we did. Oh,
yes,
okay.
it's us giving CME.
Okay. Yeah.
So based on what we're looking at here, in their employment agreements within Acclaim, the 380 providers are allocated a certain amount each year to obtain their CME hours that they're required to get to maintain their licensure. So that is simply a true educational expense for Acclaim.
Okay. So I guess my question would be, do we need to still do the CME on our side since we put money in the budget for them to go over there? So why would we have a contract that would,
I apologize. I wanted to speak a little bit to what Acclaim reimburses for from a CME perspective. Our providers do. I'm Diana Brazel.
Yeah, go ahead, Diane, thank you.
Our providers actually, with their CME dollars, they can get reimbursed for licensing and certification that's also required. It's not just going to attend class, although they can also attend classes related to their certification or their board renewal courses, certification courses. And in many cases, as you know, if I'm a surgeon, what UNT may be offering from a CME perspective may or may not be related to what I need to do to encourage or enhance my practice. So is that helpful a little bit?
that helps, but it still begs us to go back and revisit that, because if that wasn't a cheap contract, so that's all I'm saying. Okay?
Now, and Dorothy, I think.
Yes, ma'am. Yes, sir.
Excuse me, as a follow-up to Dorothy's question.
Have we?
Oh, go ahead, DT.
Have we changed some of the policy to relieve some of the anxiety from the physician attending the CME?
Well, we have continued to work on that. You're correct. We had some growing pains, right, with what we reimburse or what we don't. We have massaged that policy, if you will, in response to some of their concerns or some of their concerns about what we reimburse for.
I think this may be old news, but some of the concern was that they have to book in advance because of lodging. It's so hard to get hotel room. So
right.
So they have to front all that stuff so we can find a way to
we don't require them to front everything, frankly. If they submit, we will allow them to submit their reimbursement twice. So if we've approved the travel, which we do ask for them to request travel 60 days in advance, and that's for our clinic access, right? We want to close clinic schedules early enough that we don't impact patients. But if they are paying for registration 3 or 4 months in advance, we will go ahead and reimburse that first and then reimburse the travel expense after. That helps.
For clarification, then, back to Dorothy's question, we've got it tagged CME in the claim, and we're still showing the contract arrangements under CME education on the district finances also. As we look at the budget, Sharon, you may look and see if there's any overlap or duplication, and Park, if it's physicians out of a claim, may we move that all over to the Acclaim? At least we got it, we can see it at one spot.
It could have something to do with your residents too.
Could.
So they have to get continuous education.
Right.
Okay.
Just make sure, yeah.
Bring them all
So,
up.
yeah.
Get them on up there, Dorothy, yeah.
Now your question's brought three up.
But it's obvious, Dorothy, that it needs to be focused one place so we can get it all answered. Go ahead.
Absolutely. I think it's great questions. I think understanding that we do work collaboratively, but continuing medical education is a key focus of areas for our academic mission in general, not only for our residents, but for our departments. We actually support a lot of the educational activities, didactic grand-rounds, journal clubs, everything that happens here at the organization within the departments that help to function for the faculty. the residency programs, and the departmental functions, including some support for things around maintenance and certification that complements what they do get in other ways. So kind of thinking from a physician perspective, there's two kind of ways that we do that. We do have to do some things that are through our agreements with our employment agreements that we have to do continuing education, but there's also from an organizational point that we do have some compliance things that we need to make sure that we're in line with for our continuing ed, and happy to make sure we're always complimenting each other for sure.
Well, maybe that's the part of the report will come. This is how much we're using it. This is how the physician is using it, so that would just show a connection.
Some clarification as to where it is.
Okay.
Plus, we still got a few more chairs up here. If we
All
can bring
right.
some more
I
people
don't
up.
think I have any more.
Ladies, thank y'all very much.
You're all
Sharon,
morning.
thanks, Dorothy. Sharon, back to you.
Okay, so, that is all the.
Before you move on, let me take this opportunity, since you're talking about a claim, to introduce Dr. Michael Hochberg. Dr. Hochberg is our new president of Acclaim, and he joined us full-time on Monday. We are happy to have him. He is a practicing emergency physician, and we look forward to the relationship he'll have as a practicing physician. And okay, yeah. So we are delighted to have Dr. Hochberg here, and he's hit the ground running. And I think for his process right now, he's taking a really smart approach in that he's meeting the team members of Acclaim, kind of pretty much meeting them one-on-one, and then going spot to spot and kind of getting an idea of the lay of the land, in addition to what we communicated in the interview process that he went through. But Dr. Hochberg, welcome, and thank you very much.
And Chuck, I know he hit the ground running because we were here Monday for a meeting, Chuck, early Monday morning, and he was here. That was your first day, so welcome. Thank you. Thanks, Michael. Thank you. Any other questions for Sharon relative to any of the items concerned in item 5A on the agenda? If there's not, I'd entertain a motion. I have a motion by Dr. Weber, a second by Mrs. Debose. All those in favor say aye.
Aye.
Opposed, no. Sharon, thank you very, very much. Item number 5B, consider approval. Sharon, you must
this is on the Superior Health Plan, which was effective. This agreement brought JPS in network for their members January 1st of last year. So it's about a year and a half old. And I am requesting approval today on an amendment that would provide some additional reimbursement for the services that we're providing now.
Any questions on item B? If not, I'll entertain a motion. A motion by Dr. Weber, second by Mr. Wynn. All those in favor say aye.
Aye.
Thank you very much, Sharon. I think Scott's going to come up for item number C, the sublease agreement between UT Southwestern, Moncrief Cancer Center, and Tarrant County Hospital District. Good morning, Scott.
Good morning.
Good morning.
I'm excited to ask for your approval this morning of a sublease agreement between UT Southwestern Moncrief Cancer Center and the district, subject to General Counsel's finalization of that agreement, and capital expenditures of $4.2 million for tenant improvements, fixtures, furniture, and equipment. As each of you know, this has been in our strategic facility plan for about almost 9 years now, and as well as part of the recommendations from the Citizens Blue Ribbon Committee. This particular facility will allow us to essentially double the clinical capacity for our cancer patients at a location very close to the main campus.
Just to remind y'all, we put up the map last time. We walked through this, gave you an idea what the floor plan currently looked like. So
yeah, we might have talked about it a couple times. Yeah,
a couple times.
Yeah.
It's all been
this is a 10-year term with a couple of renewal options. And I also want to note that we will not begin paying rent until January of 2019, so the financial impact for 2019 fiscal year will only be a portion of that year.
It was vetted through planning and through previous discussion with the board too, so finance.
Yes, sir.
So yeah. Any
Are there any questions?
for Scott? Scott, I just want to ask a question about council sitting here. Is there any other issues relative? I heard something about the lease. We may need to make the motion subject to some final.
Yeah, it is subject to final negotiations between. Yeah,
words,
we're really working on
minor things that said we don't think there's going to be any issues, so we're going to make the motion whatever is subject to final.
Yes,
general counsel
thank you. We're working on some
insurance.
issues. Yeah.
So have the minutes. We'll reflect that in the minutes.
Thank you.
Is there any discussions for Scott relative to this? I know it's been vetted, looked at, and all kinds of things, so is there any question? Yes, ma'am.
Correct. The operations that we have that go there would not use up the entire space, correct?
It actually, we believe that it will utilize most of the new facility. That's correct.
That's right.
Actually.
Almost double our capacity.
Yeah.
So we're gonna do that with our current operations?
So it will have an impact on our operations, including increased operating expenses going into fiscal year 2019. We've had that analysis, and obviously there'll be very detailed analysis when the fiscal year 2019 budget's presented. We are hopeful that due to the increase in infusions and the payer mix of those infusions, we might actually be able to break even from an operating expense standpoint, and that we hope will be reflected in the 2019 budget.
Dorothy, do you have a question? I'm sorry.
I know I've seen it, I'm not opposed to it, but I know when we originally go in, it's going to be with our current operations. Unless you have a backlog for a waiting time for infusions, we're expanding that. But it doesn't mean that we had the staff up for 29.
No, that's correct.
There will be. So I think we'll be moving in with current staff, and based on your needs, you will add as you I know when we do budget, we will anticipate some growth that will go in there. But it's my understanding now that we would go in with current staff.
Yeah.
Unless we have some backlogs of folks waiting, I wouldn't see that you would automatically staff up for the whole facility.
Sure.
And that's what you're saying.
Yes.
Right. You're not.
Yeah, and I'm glad you brought that up, because it really is important that we've had that conversation internally, that this meets current demands, but also gives us room to increase capacity, whether that's through changes in our operating process within that given location or otherwise.
Okay, so we're moving an operation there, and so what's happening to the space where they are leaving?
Sure. And as you probably are aware, we actually own the building where our current cancer facility is on Terrell in Hemp Hill. Because we own it, we have a wide variety of options that we're looking at, everything from selling that particular property to repurposing it. Throughout that analysis, we'll be looking at impact on operating expense in terms of what we do with that building, as well as the ability to raise capital. As you probably also know, as we've probably discussed in this meeting, that we pay almost $1 million a year in lease payments in this area. So we need to balance and weigh the future use of that particular property.
So it's a good chance we'll move some of our operations that are in leased space to that space.
Could be a possibility. Another possibility is our goal is to reduce that lease space cost that is just kind of money going out the window.
Right.
And we think we could do a whole lot better job of dealing with that. And we're going to look at alternatives to do that. But to your point, you've got a facility that was never built, as Dr. Basham, who's in the audience as well, and Patrick as well will tell you. It's basically a house. I mean, it's not fit for what we do, and it's a challenge. And I've always made the comment, we've got some of the best people working with some of our most challenging patients and patients that are in the most difficult of situations, and we're in about the most difficult facility to do it in. So I think this will not only enhance the care, but it has the opportunity for not just the growth of our patient base, but we're looking at other opportunities to put facilities in that building if possible.
Yeah, Warren, I think that question came up in planning too, but we're talking about taking some of this lease $1 million a year and finding places to put it, yet we're approving a new lease. I also think it's a unique opportunity where it's located in the hospital district. It's cancer services. We know we're going to probably, if you read all the that's an area that we're going to have to continue to have
Cancer is a growth area?
Well, let's be realistic, to serve the needs of our mission.
Sorry.
Yeah, it is. I'm not saying we're in that business. I'm just saying it is certainly part of the mission. We're going to continue to see. It's a unique opportunity that came available. If you know where it's sitting over there right next to Baylor, it's got transportation, it's got all those things. So I think also the uniqueness of the time, we will grow into it. Like you say, Dorothy, and then Warren brought it up too, just because we have a few extra spaces, we're not hiring 10 extra people to stand around. they will staff it, and it will be built out as they grow.
Yep,
It's
thank
so
you.
also, there's a uniqueness of the opportunity here to go ahead and move, so, again, I think anything else?
Charles, if you don't mind, Dr. Kabosh and Patrick do an
Dr.
outstanding
Kabosh,
job.
yes.
And Dr. Kabosh has taken our cancer center and moved us in a direction we want to go. And he is an excellent provider. And if you talk to any of our cancer patients and those that are struggling through some of the more difficult situations, the kind of care that he gives and some of our other providers are excellent. So Dr. Kabosh and Patrick need to be recognized for incredible work they do.
Any other discussions for Scott relative to the sublease with UT Southwestern? I would entertain a motion along with the comments, have the minutes reflect that we can finalize the insurance issues. I have a motion by Mr. D.T. Wynn. I have a second by Mr. Debose. All those in favor say aye.
Aye.
Opposed, no. Thank y'all very much. Scott, thank you. You're gonna, the next item is approval of the interlocal. Miss Zelia Ball is here. My gracious, another new person. Welcome to JPS.
Let me introduce Zelia to y'all.
Yes, our new
What we like to do is bring new people in on Monday and have them report to board committees on Thursday. We actually was hoping this meeting would be on Tuesday because we gave her way too long to prep for this. But Zelia is a gift. This is a hard area to recruit. Looking for a senior VP of behavioral health. Everybody else in the Western Hemisphere is doing the same thing. And there are a limited amount of people that do this. Zelia had a great career in the state of Alabama, and she was with a facility that has a lot of parallels with JPS in their service model and their patient base. She then was asked to serve as the Commissioner of Mental Health for the state of Alabama, and that gubernatorial appointment put her in the limelight. She then left that position to do one of the most noblest of things, which is an incredible person. When you give up your career to go and be with your mom and your dad because of their situations, it speaks to the person, and that spoke definitely to the person that Zelia is. And then to have her here has been pretty phenomenal. So I think y'all will get to know her like we've gotten to know her in the time she's been here, and she's going to be quite an attribute to us. I'm proud to have her. So with that, don't fall off that pedestal and tell us now what you're trying to get from this board. Yeah.
Good morning.
Good morning. Welcome.
Thank you. I'm honored to be here. I'm here today to ask for our action item approval of a proposed revised interlocal cooperation agreement for the provision of education services. This provision of educational services for adolescent patients admitted to Trinity Springs Pavilion ensures the continuation of education and development for youth in Tarrant County faced with mental illness. This results in improved health care delivery as well as improved outcomes for this patient population.
We have, this is a continuation. We have had this before.
Had this
and you all have seen this and approved of this before.
Yep.
We just didn't tell Zelia that. So we wanted y'all to.
Continuation.
Right.
And there are no costs associated with this contract.
That was, yes, thank you.
Yeah,
That last point.
Yes,
you did
I should have said that first,
yeah.
right? I should have said that first.
Now I know why she was appointed as she's got that political already in her. I can tell that.
Exactly.
She held that back the last moment. Is there any questions here? Again, this is a renewal of what we done. Yes, Chuck.
In 6 months, I'd like to know whether she'd rather work for the governor of Alabama or Mr. Early.
I can give you that answer now. I think Mr. Early wins.
If there's no additional questions here, I'd call for a motion. I have a motion by Mrs. Debose, second by Dr. Weber. All those in favor say aye.
Aye.
Again, welcome very much. You know, I know this is finance, it's not the board's, but I'm going to take the liberty, since Steve asked me to sit in this morning. You know, as chair of the board of managers, I have the pleasure of attending a lot of functions within this district. I'm very proud to do that because I represent this board. I spend a lot of time in the communities representing this. But there's two people in this room I did not know, Zelia being one of them, obviously, and Michael being the other. You know, they moved to come here. I had the pleasure of talking to them right after they accepted their positions. There was no hesitation. All you got was, we're excited We can't wait to be a part of JPS. We are looking forward to joining that team. And so to both of you sitting here today, in your first week in major positions with this district, I say welcome to Fort Worth and welcome to JPS on behalf of the board. So thank you all very much.
Thank you. It's an
See you.
honor to be here.
Well, thank you very much. Which would take us to item number E. Kathleen, you always save us money, Kathleen. So the proposed amendment to Simmons is number E.
Good morning, everyone.
Good morning.
I have two proposals in front of you today. The first is a contract for Siemens Medical Solutions for a second general radiology room in our emergency room to help with our process flow of moving the patients through. Currently, there's one room, and this would give us an additional. And this will help us prevent from moving patients from one side of the street to the other when we have high volumes. This contract is for $562,950.
Any questions for Kathleen? Sounds like it's convenience and needed, so. I have a motion by Mrs. Debose, second by Dr. Weber. All those in favor say aye.
Aye.
Thank you very much. Kathleen, I think you're also handling F.
The second contract is with Philips Healthcare, and this is for approval for the replacement of 2 CT units in the ED again. This is a contract for just over $1.1 million. This replaces our 2007 CT unit and our 2009 CT unit. It also gives us additional availability to do brain perfusion for our stroke population, which we currently do not have.
Okay.
Good deal.
Good.
Any discussion relative to that? I have a motion by Mr. Wynn, second by Mrs. Debose. All those in favor say aye.
Aye.
Opposed, no. Kathleen, thank you very, very much. Yes, DT. Kathleen, one moment. Kathleen?
Kathleen.
One moment, please, DT.
On the previous one, the one with Siemens. On number 2, item 2, the GPO, which GPO is that?
Vizient.
Okay, and then is that bypass our RFP that we're using on their RFP, or?
Vizient uses an RFP process, so we can obtain contracts through that GPO, and then we continue to negotiate pricing from the GPO.
So the streamline.
Right, so we can obtain the best price
That's
possible.
the best price available.
Thank you.
Yeah, good point, DT. Thank you, Kathleen. Which I will turn to General Counsel, see if there's any other thing under item number 6.
For the month of April, there were 35 contracts negotiated that were under 200,000 and 2 contracts negotiated that were between 200 and 500, and those are on reports that are on the portal.
And those limits were established by the board a couple of meetings ago, so anything else? I have been advised there's nothing for closed in finance. Is there any other business that needs to come before this committee of finance? There being none, we will stand adjourned at 11 o'clock. Thank you, ladies and gentlemen. Thank you all for being here.
let's go ahead and call the Human Resource Committee to order. There being no citizens wish to address the committee, then we will move right into the agenda. Our first item on the agenda is approval of the minutes from January. Are there any corrections or to the minutes?
Move approval.
All right. All right. Then moved and second. All those in favor of approval signify by saying aye. Opposed by nay. Okay. Next on our agenda is Ms. Walker on the policies. Okay. Since we have to do them one at a time, right? Okay.
We always ask that. We always ask that in hopes that you will say, no, you don't. You can actually do them all in bulk. One day. One day.
Okay, good afternoon, everyone. What we would like to do is do approval of the following HR policies. The first policy is HR 4800, performance appraisals.
Okay, are there any questions on the HR 4800? All right, it's been motion. The second, all those in favor signify by saying aye. All those opposed by nay. Okay.
Okay. Next policy is HR 100, job descriptions.
All right, are there any questions concerning HR 100 job descriptions? There being no questions, I will entertain a motion for approval. Okay. Second by. It's been moved and second. All those in favor signify by saying aye. Those opposed by nay. Okay.
Next is HR 3100, military leave and supplement.
Are there any questions or concerning the military leave and supplemental policy? There being none, I would entertain a motion for approval. Okay. Okay, been motioned by Chuck, second by Charlie. All those in favor signify by saying aye. And those opposed by nay. All right.
Last and final is HR 4700, 90-day orientation period.
Okay. Any questions on this? Now I'll entertain a motion for approval. Okay. All right. It's been motioned and second. All those in favor signify by saying aye. And those opposed by nay. Okay. Motion passes. All right. You're still up.
Yes, ma'am. Awesome. Great. Do you all have any questions about that?
I won't have to get.
Why did it go out here? Okay. Okay. Is my orange approved? Is it okay for me to move forward? It is. Okay, wonderful.
The only thing that would make you look better in that jacket is if it was in a room. It is your color, though. Indeed.
Thank you. Thank you. Exactly. Right. Exactly. Exactly.
I thought it was blue, and I thought it looked good. Chuck and I think it's great. We were debating whether it's blue or green.
All right. I know it. I know y'all have had too much sugar.
It's fine. It's HR appropriate. So, I mean, we're right in line. So.
All right.
Okay. Well, this afternoon, what I would like to do is provide an update to the Human Resources dashboard. If we could look at the very top and focus on FY18 quarter 2. And again, as we go through this dashboard, our focus is benchmarking this data against Saratoga. So looking at the first piece here is total voluntary turnover. For quarter 2, we ended at 10.54, and Saratoga benchmark is 11.2. And that's great because we were lower than the industry standard for that total voluntary turnover. Next, we have involuntary turnover, where we ended at 3.93. Saratoga benchmark is 2.20. Total turnover is 14.48, and looking at the Saratoga benchmarks, we ended at 14%. Another piece is the 1-year voluntary turnover. For the end of FY2, we ended at, for quarter 2, we ended at 17.8, and Saratoga benchmark is 17.90. So when we look at how we ended for quarter two, we're doing pretty good in these areas, looking at turnover overall as well. When we look down at the very bottom and we look at the job classes, and this is again done by our job families that we have within JPS. Again, this is the measurement period for October 1st, 2017 to April 30th, 2018. And this provides the overall turnover for each of the job families that we have. So when we look again, looking at the information that is provided and looking at the turnover, we're doing pretty good when we're looking at the benchmark against the Saratoga data. Are there any questions?
When I'm looking at the voluntary turnover, and I see in the police department, is there any reason that, have you identified any reason why theirs is high? Is it, I know we're competing with other police departments.
We are. Okay. And again, we have to think about it when we look at theirs because it's higher. The police department has a different measurement that they have to follow when it comes to end of employment. Mm-hmm. So we have to follow the state laws against that. So anything that occurs with the state laws, it supersedes JPS. So our policies do not have to abide by that. So if there's anything that is aligned with the state policy, we do have to move forward with end of employment with that group.
Now, if I'm thinking on the voluntary turnover is the one that we focus on, because involuntary, that's the one we are asking to leave. Mm-hmm. So on the voluntary ones is the one that we would be looking at, trying to keep them. And so executives is pretty high. I just wanted to mention that. So, okay. Anybody have any questions?
I've got a question. Yeah. So how, the total number of vacancies for all these departments, and up at the top we have a comparison to quarter one and then to 17. The total number of vacancies, is that getting better or worse? Are we hiring more nurses, or is that shortage expanding, I guess?
Well, and when you look at the vacancies, again, looking at FY 17, we did end at 287, and then when we pulled this data through April 30th, 2018, that's where we ended at 335. But again, the vacancies, that's weekly data that we receive, and when I received that report last on Monday, we were at 291. So again, this is where the date was pulled, April 30th, 2018, and there are less vacancies than reported out here. To answer your question about nursing, right now is different modalities that are in that vacancy list. Nursing is really at a good point now because we do different recruitment fairs. It's not a high turnover for nursing, and they're doing very well. So we're coming up with different techniques, different strategies to be able to focus on nursing.
Well, I guess my point is, excuse me, at this point last year, did we have 175 vacancies? And the year before that, did we have 200? Are we hiring more nurses than that's leaving? I mean, what is the 146 vacancies, and I'm just using nursing as the example. Is it getting better, or is it getting worse by having more vacancies year over year?
I would say that it's getting better.
Okay.
Again, because that's where we partner very closely with our chief nurse, Wanda Peoples, to think about different ways. Of course, we know that nationally, everyone is struggling with, recruitment of nurses and, what are different techniques that they're utilizing to be able to attract individuals to JPS. So it's at a medium right now. It's not bad and it's not the best. Can it get better? It can, but I think everyone is dealing with that right now in the nation. But for us, we're at a good point with our recruitment for nurses.
Okay. So maybe what we could do on that is next month go back and look and see where we were 2016, 2017 to see if we really are moving the bar or we staying where we are. I think that's your question, is that we know we're doing good, but were we that point last year and the year before? So maybe we can pull one of those out the next time and just look to see how we've improved for the past years. Okay?
Yes.
All right?
Definitely.
Okay. Yeah, DT.
I have a question on the information management technical. Is that part of the information technology team?
IT.
when you look at 27 or 28% turnover at the middle management level, it concerned me because of the IP loss, or are we hiring the right people, or are we not hiring the right people, or it's just opportunity somewhere else?
So let me explain to you these two job families. So when you look at management technical, is that what you're looking at? And then management, we put management technical because we have positions that could be director of processes, and they do not have people reporting to them. So for us to be able to distinguish the difference between management of people and budget, and then a person that does have a leadership position, that's how we look at the difference. Now, these could be project managers, it could be director of process improvement. That is the difference. So these are not truly leadership positions. That's why we call it management technical. And we picked that piece up when we did the market data, looking at what the industry was looking at, you know, based on market assessment. So that's how we were able to distinguish the two, because it's a complete difference when you look at, you know, leadership, management of people and budget, and then you may have someone that has that title, and they may just be management of a process.
But that is concerned too, because they're the one that manage the workflow and the task, right?
Yes, and it's different across the organization. I mean, it could be manager of business management, business analytics. Is all different types of jobs that fall into this job family.
That's why it jumped out at me. So is it alarming that we need to help them focus to see how do they retain people or recruit people, because we have unfilled position? That's one. Because at some point, it's going to be a toll on the leadership team or the people below, because they have to take over those tasks. But
okay,
all right,
definitely.
Let me speak a minute to the executive side, because I think it is important. If you're doing, in my opinion, if you're doing the right thing and you're bringing in the right executive team and you're bringing strong executives in, you're going to get cherry-picked by a lot of other organizations to want those executives. And that's where you're going to get your voluntary turnover. The other thing that I appreciate this board so much for, and I think will have an impact, is your process of looking at retention and the things that you've put into place that Bill will come up and discuss later for the annual incentive and the long-term plan. We're an organization that has never had one of those. So if you're part of this organization and you're doing really well, you're going to get noticed industry-wise. And when you get, Wayne Young's a prime example, you're going to get noticed industry-wide, and you're going to have the opportunity to go somewhere else. And you're going to go somewhere else that's going to probably significantly change the salary and a title in that case. So to me, it's an odd situation, because if you really are doing well, you have more of an opportunity of others wanting your good folks. So what you got to figure out how to do is, how do you maintain and keep those good folks? And as we've talked about before, people look at the public hospital and say, well, it's just the public hospital. You know, why would we have that pay scale, or why would we do this, or why would we have that retention? You don't compete with other public hospitals.
No.
You're competing in this market with Baylor and HCA and everybody else. And quite frankly, I like THR and HCA and Baylor. I just want better people working here than work there. And I want the best people I can possibly get. So when you have those executives, it is a challenge. It's constantly a balance. And then I think to the involuntary, I think the demands that are placed upon us as an organization is for you to be doing your job and do it well. And if you don't, and that's not a fit, we're probably not going to wait 6 years to go through that process. We're going to say, you know what, there's probably a better fit for you somewhere else. So it is a challenge, and I certainly, Dorothy, don't mind you bringing that up, because it's concerning. Those are high numbers, but it's a low percentage of people, and it's 22, and then you try to figure out when you lose 3 or 4 or they go elsewhere, your stats look pretty tough. But my biggest comment is, I applaud and thank the board for putting a program in place that is a hopeful attempt to retain those people.
That was one.
Excuse me.
Go ahead.
We all have different business models that we manage, but I've known in my career over the years, usually when my competitors are coming, they're coming from my top people. They're not coming from the person I'm saying This one doesn't do very good. They always seem to come for the top. So again, I think your point's well made, Robert.
It's a good time for us to look at that because we set the long-term TIF in to address that. So that might mean that we have to go back and look at that, because if that's not working, that was the piece that we put in place to kind of hold them, so.
Well, and just now, you just have your payout. So now people will start seeing that. Right at this point, we've had a great deal of discussion, and we've talked about it, but we went from zero, we had nothing, and everybody understood. I'm actually fortunate to be able to keep the executives we had with no type of a plan. And I'm proud of them. But now we've talked that, and now they'll start seeing that, and now we'll see, hopefully, the benefits of that, because up to this point, there's been discussion, and some of the execs didn't even know what kind of payout they would get during that time period, because you don't quite know. So now we're getting to our first year of that 3-year payout. Now we'll start seeing, I think, those retention numbers look better. It'll certainly be a more difficult case. Now, in some of those cases, when there's a huge bump, you can't even compete with that. Or let's say just guessing. Let's just say we had an executive and somebody wanted to provide all their children free schooling. I can't compete with that. So there are some things that we can't compete with.
Yeah.
A quick follow-up question.
Yes,
on
sir.
The information technology. The turnover and all that stuff is pretty low. Does that include people that we insource?
No, that does not include individuals that go through contracts. So when we're capturing this data here, it's all of our active employees that are on our JPS payroll, not anyone that is brought through an agency or any type of contract. It's our people that we're focusing on. Because when you look at contractors and you look at agencies, again, when they come in, they're coming in to focus on the project, they're coming in to focus on a plan that needs to be initiated quickly and then turn around. So we don't capture that data. And then just looking at industry standards within healthcare organizations that I network with closely, they're not capturing that data either. So when we do this, we look at it on a best practice method.
The reason I'm looking at this is the cost of onboarding, right? Do we have concern with outside entity for onboarding?
Do we have concern?
If they have turnover themselves.
No, we don't have concern, but that's why we focus on, number one, before we even go to an outside agency, we communicate and ask leaders to utilize our process first to give us time to be able to save dollars before we do go to an agency. So whenever a vacancy does come open in the position, that's where the talent management team does meet with the leader to have that conversation on, what are they looking for, what type of talent, what are key initiatives that are currently in place that they need to work on, and let us utilize our pool first. Let us utilize our recruitment before we do go to an agency. So we focus on our in-house before we go outside first.
The reason I'm zooming on this one, to tell the truth, because this is the area where the intellectual property and the process is so important, because this thing happened, we've messed up every department because we depend so much on our system and all the WeWork and all that stuff that we're trying to help other area. That could be just the noise coming from a certain area. That's why I'm zooming on this one.
Right.
So just a thought around it to make sure that we bring that level down for the entire team on the other side.
What we want to make sure, DT, is when you ask a question, we always like to have a big drill going on outside, because it really does help a lot. Yeah, so that's, we make sure as soon as DT talks, we have a big drill going off in the hall.
And then one other thing too, Roger, to be able to piggyback on your question, we did get the data for the total vacancies. So when we ended the year, fiscal year 16, we were at 474 vacancies. And then when we closed the year, FY17, we were at 287. So we have improved. Yeah.
Any other questions? Okay.
Okay.
Thanks.
Thank you.
Yeah. Okay, Bill.
So my purpose in presenting today is to discuss where we are relative to the annual incentive plan and the metrics that this committee and this board approved in January of this year, and talk next about the long-term incentive plan that Robert had previously referenced. I've tried to give you a visual, informative snapshot versus looking at the individual numbers, and I probably need to forward that. So intuitively, green is good, red is not so good, and yellow is making progress, right? That's the intent. So we have these 10 metrics, and these metrics are by and large metrics that we've seen before in the years past. The 2 quality metrics we have changed this year to focus on our surgical site infections, both from an abdominal hysterectomy point of view and a colon point of view. Taking our historical performance, we have presented, and this committee agreed, to look at a threshold level of whatever actual was -1, and then setting statistically significant improvements at the target and the stretch level. So this is through March, so we've got yet 6 months to go, and these numbers could change. We hope not, because we think we're doing pretty well in those 2 areas. One of the most significant improvements we've made, I think you'll agree, is improving days to next available new patient appointment. We're at 10 right now out of 14 clinics, and that's dramatic improvement. We have recognized a problem with our specialty clinics and thought it would be a very good focus for us this year to improve that flow. You can see it's still red, but this is through March, and April results have begun to show some traction. I think we're in the low 90s as of April. So we hope that we can hit at least threshold when it comes to the end of the year. Service, HCAHPS, which is our perception of patient perception of service and care relative to the inpatient side, is right at the threshold level. CGCAHPS, which represents our overall perception of care in the clinics, is a little bit above threshold. We've got some ways to go. And ED CAHPS, that speaks to the patients in the ED, exceeded all of our expectations, and they're certainly performing well above the stretch target that we have in place today, in spite of the volume that we've seen. Yeah.
If you look at where this place was.
Sharon reviewed with you the FTEs per adjusted patient day in the finance committee, and we're performing well there, below budget, and certainly above our stretch target. Operating margin, we're right there at the threshold level. I think this was through March. I think if you look at April, which many of you were in the finance committee meeting, saw that there was a little improvement in our bottom line. I think we're right at threshold at 0.2%, meaning we've got a lot of opportunity before us over the next now 5 months since she gave you the April report. Cost per adjusted patient admission. Not doing so well here, and that's part of our long-term incentive metrics, which we'll discuss on the next portion of the agenda. Achieve and maintain high levels of employee engagement. That survey will not take place until August, and we won't know the results until September or so. So we assume that we're going to do well. We've done well the last 2 years. There's no reason to believe otherwise. But that gives you some sort of a feel where we are mid-year on our annual incentive plan. And to remind you, that plan is for directors, managers, and above, eligible for 10% of their base salary. Everyone in the organization participates, and those below that level would be able to participate at the $500 per employee level. So I think we're making progress. Now, the next portion of the AIP.
Hold on a minute, Bill.
I'm sorry.
DT had a question.
On the perception of care,
Uh-huh.
we'll throw your lifeline here. Because we're at 72, and we target and stretch is 79, at what point do you think we have to level off because of, we have building perception of an older building and all that stuff. Just talk to us about to see where is that reasonably will kind of level off.
We plateaued. 2 years ago, we hit the 78th percentile. And NRC Picker, which is our vendor for the surveys, led us to believe we could expect that once you peak at a level coming from a much lower level in a very short period of time, you're probably going to see some recidivism in your scores. And we did. We dipped below the 72nd, went down to the 71st, bounced back up. We're seeing results as they told us that we could anticipate based on their previous relationship with institutions all over the nation. So some months were a little bit better. Some months it seems like we're in that level that we fall back to this particular percentile. And this is percentile ranking, not mean score, right? And this just, to me, validates the fact that we have to continually work on this, because you've seen PIA's report on voluntary turnover, involuntary turnover. We've got people coming in all the time. This is an area that you constantly have to pay attention to. You have to train, and you have to validate, and you have to observe, and you have to shadow. And in spite of doing all that, which we've done, we still hit these kind of levels. But I think it too speaks to the fact that even though we have a facility that's outdated, we're still able to achieve relatively high levels of patient satisfaction. And when you think about where we were 5 years ago, I don't, but it's a fact. We've come a long, long way. Do we have opportunity? Do I think we can do better? I want to believe that. I do. We just need to be more consistent.
Right. I'm more looking at from a different perspective. Things that we can impact, like access, co-pay deductible, asking for questions about their payment. Obviously, they're gonna give us a different rating. Interaction with the doctor, the nursing staff type thing. Those that we can improve scheduling, with building and certain physical things that we can't move the number. Should we take a look at that and try to understand so that we don't have falls?
I hear what you're saying. I do. And I think the fact that we do have the majority of our rooms are semi-private, that probably, I don't have validated research results on that, but that intuitively you would think if I were in a different environment and I didn't have a curtain separating a bedmate, that, yeah, I might feel differently about the organization, right? I think one can draw that conclusion. Most organizations today don't have the predominance of semi-private rooms that we do, right? So that just implies that we've got to be a little more vigilant and diligent about how we
that point, DT?
Just looking for impact and not something we can't impactable. I mean, that's nothing we can do. Right?
Sure. There are some things sort of that same way. Our challenge is on the second floor, and Dorothy has talked about this and become such an advocate for it. But when you're in that kind of a setting and you're waiting for your appointment, you're in an uncomfortable position, you don't like sitting in the hallway, it's even more difficult to get that patient SAT scores, and we can change that. I mean, that is a facility change, and I'm not just saying we just need to look pretty. I'm saying that makes an impact on the overall care that you perceive you receive, rather than sitting in a hallway waiting for your appointment. So your point's right on.
No, we improve a lot, but sometimes when you don't move the number, it makes it harder for the environment.
I agree.
All right. And this is our third year into this, and I've asked Steve Sullivan to kind of be at our next meeting so that we can really look at our trend. There are some things that are pointed out. I went out and looked at, compared us to other hospitals that have all the private rooms. And some of those numbers that we're saying, we're plateauing, they got all the private rooms, and we are still better than them. So I know we talk about that, but if you look at, and you can pull up the several of the hospitals and compare them, in that number, we are right there with them, and they already have all the private rooms. So I'm thinking it might be something else. And so at our next HR meeting, I'll have a different graph for us to look at, and then for us to do some deep dive in some stuff that's going on and talk about where we want to be starting in
Did you compare
next year.
other community hospitals or private?
Yeah. Well, we have the, I can compare us to Scott and White. I can go into, it's all out there on the internet, and compare it to other private hospitals, Harris, the ones here. I can do it, look and see what Scott White's doing, Breckenridge. Yeah, I can pull all that up and we can look at it.
Yeah, these are mostly lag indicators that are publicly available, so they've got some age on them, but it's.
And you can drill down and it'll
true.
tell you what month they are. It's from 17.
Right.
So, but we can look at that, and so I've been trending that, and that's kind of part of the information. When we look at it, we can have some other hospitals that say, this is what they are. We're doing good, but there's.
The next slide is still about the annual incentive plan, but it's a different way to look at it. So if you look at all of the individual metrics based on the weight of those metrics, collectively, the payout is based on the collective performance of 10 metrics. So this shows you, from a dashboard perspective, how each one of those are performing relative to threshold, target, and stretch. And collectively, it's 120% of target to date through March. Again, we've got 6 months to go in the fiscal year, but this gives you some perspective of potential payout if everything stays as it is today.
Any questions on that? Why is our primary care?
What was the question, Doctor?
Why is
Like the
primary
primary
care
care
rate so low?
Are you back on service perception of care under primary care?
CG caps?
CG cap.
Oh, I'm sorry. Yeah. That has been a challenge for us for a number of years. We haven't seen any regression there. We've seen only improvement, and we continually struggle with getting that overall perception of care from the primary care docs, and we work with them greatly. So none of us are happy with where we are percentile-wise. None of us are. But relatively speaking, we're making some progress, not as fast as we had hoped.
Chuck, have you seen those questions that, the questionnaire that they call and ask they do follow-up on? Some of those questions are hard to, it's an absolute. It isn't kind of, if they say, how is it, if they put you at a 3, that just doesn't matter. I mean, if you're not at a 4 or a 5, and it's kind of hard sometimes, because I got one of those surveys, and I was thinking, okay, I can see why this would be difficult. But we are improving.
It's a lengthy survey. It is.
It is.
But it's
and
standardized.
I don't know if everyone have looked at that. It might help us to understand it a little bit better if we kind of looked at that. And there are some questions there that it's hard for you to do an absolute on. So I have a feeling if it's kind of like when we changed the evaluation here, we went from 1 to 5, 1 to 4. So you had to do something when they put that 3 in there. Folks just, I think they think they're doing us a good deal by giving us a 3, but it's a 4 and a 5 that we actually need. And so I think that's what's wrong with that form, but since they won't let us change it, we just got to figure out how to educate folks. When you get this, you need to be thinking about us in the 4 and 5 range. The 3 doesn't matter. And I think folks are thinking that's a good score, because I talked to somebody about their survey, and they said, oh, I gave them a good score. I said, what did you give them? A 3? I said, oh, no, that was not a good score. Right. And they said, but it's 1 to 5, and a 3 is good. I said, only in school. So I think that's a part of that education that we've got to do.
But we are precluded from coaching them because
Well.
they say we can't do that, right?
I know, but isn't there, I was, when you get the survey, you know, I went to my doctor's office, and they gave me a little information sheet that said I would be getting a survey. And all it said is the scores, that, you know, this is how they ranked it. Now, I don't know if that's right or wrong, but that's what they passed out in the, well, they didn't pass it out, it's in a little waiting room. I thought that was, I don't know if it's cheating, but that's what they had in their waiting room, is something like, you will be, as a follow-up, you will be getting a survey. It's important that you answer the survey. And they just talked about the scoring for it. And 3 would not be counted. I remember that extinct. I'll try to find it.
You're going to give me a 3, don't send it in?
Dorothy, it wasn't cheating, it's just being communicated with.
Well, I'm just, that was what was in the waiting room, so I thought, oh, okay.
She can't fill it out as conflict of interest.
That's right.
Okay. Any other questions on that?
Okay. The next agenda item is to discuss the long-term incentive plan. And to refresh your memory, there are 2 metrics, and this is a 3-year plan, and Robert referenced that a few moments ago. We're in period 3 of that 3-year plan. There's been no payout whatsoever. This is designed to be the average of the performance over the 3-year period, right? The first 2 years are in the books. They were different metrics. They were reducing potential harm and ACSC type metrics that we proposed in latter part of last year and early in January, that those weren't metrics that were really sustainable for us, and you approved that. So we introduced 2 new metrics this year, which are going to be averaged with the previous 2 periods of old metrics, and these are more meaningful. This is about our measure of quality, and it's a leapfrog metric that is nationally recognized, perhaps not nationally embraced, but certainly nationally recognized. It's 30-some-odd metrics that roll up into a composite score. And we think that we could be in an A, should be in an A over the next few years, sooner than later. And we thought that another financial metric, which we need to certainly improve upon, is efficiency and productivity. And a good measure of that is cost per adjusted patient admission. So as you saw on the previous annual incentive plan, we're not doing well there. But in regard to Leapfrog, we just received the results of that score in April and are very pleased with the outcome. It looks like we're on that glide path that we had hoped we would be toward an A. We're not there yet, but given the progress and the accomplishments and the consistency that we've achieved, we truly believe that we will be an A in a very short period of time. But B was the target, and this reflects that achievement. And the final results for this come out in October. So this is kind of a preliminary mid-year report, but that's pretty indicative of what we might see in October as well. So we're hitting the target, a little bit above target if you interpolate on the Leapfrog metric, and we're certainly well below threshold in the cost per adjusted admission. So when you look at the next slide, which is similar to the AIP that I gave you from a dashboard perspective, a dial perspective, you look at period 1, period 2, period 3, which we are 6 months through. The overall award, if you will, if everything stays the same as it is today, would be 108.14% of target when you consider the performance levels of the previous 2 years and where we are year to date. So I'll be happy to answer any questions that one might have about AIP or long-term.
I have a question on the previous page under the efficiency something, hospital efficiency.
Cost efficiency?
Cost per adjusted patient admission?
Right. What are some of the key number that may move that number by $100 to get to that target point? So the salary, I know the salary benefit contract labor and all that stuff. What are the one that?
What is the one
That kind of
leading indicator that might move that lag indicator, so to speak? It's going to be around salaries and wages, obviously, supplies, to the extent that our revenue, net revenue increases, that has an offset as well. So we know where we need to be. We just need to get there.
Okay.
And that fluctuates. That fluctuates fairly significantly from month to month. And it's probably not a good indicator to look at on a monthly basis, but on a quarterly basis, I think it pretty well gives you a good picture of where we are.
Any other questions? Thank you, Bill.
Thank you.
Okay. I think I have one more item, and it's just for information. And then it's our time. This is for my board, for all of us. It is now time for us to start working on Robert's evaluation. You know how long it takes y'all to get the information back. So we came up with a schedule this time. Robert is going to complete his self-evaluation by June the 22nd. And then we will send it out to the board shortly after that, and about the 25th, and that'll give you to July, end of July, to get your information back. Now, I'll be asking you for it, I know, in August, but we want to have it completed by September, so we won't go into March of next year before we get this evaluation. So came up with a little schedule, and so we hope to have this completed, and we'll be able to review it in September, because that's only fair that we do this. We continue to drag it out to the next year, but this time let's try to, I'll just send you emails and I'll just call you until we get it done. But we're going to start it early, and Robert is going to do his self, and that kicks us off, okay? No, I'm not about to do that, DT.
I think you're kind of saying offender. Even use plural.
Yeah, and I can thank them real quick and they'll know. But it's serious, and so I just wanted us to have an opportunity to cover it. Is there anything else that anyone needs to bring before the committee? Okay, there being none, then we are adjourned. All right.
There you go.